Hi, my name is Sheri Smith, and I'll be doing my project on cystic fibrosis, so let's get going. The description and major characteristics of cystic fibrosis is characterized by buildup of thick, sticky mucus that can damage the respiratory system and cause chronic digestive system problems. In the lungs, the mucus can clog airways and increase the rate of bacterial infections. Over time, mucus buildup and infections result in permanent lung damage, including the formation of scar tissue, which is also called fibrosis, and the cysts in the lungs. Digestive issues can also occur and include damage to the pancreas, which in turn impairs the production of insulin and digestive enzymes. This can lead to diarrhea, malnutrition, poor growth, weight loss, and a possible form of diabetes known as cystic fibrosis-related diabetes mellitus. Cystic fibrosis is a common genetic disorder within the white population in the United States. The disease occurs in 1 in 2,500 to 3,500 white newborns. Cystic fibrosis is less common in other ethnic groups, affecting about 1 in 17,000 African Americans and 1 in 31,000 Asian Americans. In the past, this used to be a fatal childhood disease. Modern medical advances and treatments have helped people with cystic fibrosis to live well into their adulthood. Other names for this disease include CF, cystic fibrosis of pancreas, fibrocystic disease of pancreas, and mucoviscidosis. I will be probably calling it CF from here on out. Molecular cause of cystic fibrosis. In normal conditions, the CFTR gene provides instructions for making cystic fibrosis transmembrane conductance regulator, a protein that contributes to the regulation of ions, like salts, to go in and out of cells. These cells are special in that they produce mucus for sweat, saliva, tears, and digestive enzymes. In addition, the CFTR protein also regulates salts that cross in and out of cells for the purpose of creating normal functions in organs like the lungs and pancreas. Cystic fibrosis is caused by mutations of the CFTR gene, and more than 1,000 mutations of this gene have been identified in people with cystic fibrosis. Amazingly, most of these mutations change only a single amino acid in the CFTR protein, which is made of hundreds of amino acids. Or the mutations may delete a small section of DNA from the CFTR gene. As a result, the amino acid or DNA deletions prevent the cells to function properly. This creates abnormally thick and sticky mucus, which can obstruct the airway and glands. This is a picture of a chromosome that we have in our cells, and where the yellow arrow is where the cystic fibrosis gene is located, where there might be some mutational problems there. I think this is a pretty cool picture, actually. Mode of inheritance. This condition is inherited in an autosomal recessive pattern, which means both copies of the gene in each cell have mutations. The parent of an individual with an autosomal recessive condition each carry one copy of the mutated gene, but they typically do not show signs and symptoms of this condition. The parents would be considered carriers. There's a big storm going on outside. If each parent is a carrier, the odds of their children inheriting the disease are as follows. There's a 25% chance of not inheriting the disease and being asymptomatic, a 50% chance being a carrier and being asymptomatic, and a 25% chance of having the disorder and displaying all the symptoms of the disorder, including death. Often the case where families will be surprised to have their children with CF because both parents never even knew that they were carriers of the disorder. So this is an example of how this can happen. Up at the top left corner is Arnold and Arlene. You can see that they're older, 80 and 79. Arnold is not a carrier and doesn't have the disease. He has the genes capital A, capital A. Arlene, on the other hand, has a capital A, small a. The small a is the recessive gene. She is a carrier. But because Arlene and Arnold are so old, their parents and grandparents and great-grandparents lived in the early 20th century and into the 19th century. There was just no way of knowing about cystic fibrosis in those days. So Arlene never even knew that she was a carrier. They ended up having Sam. Sam is also a carrier, but because Arlene doesn't know she's a carrier and is asymptomatic, Sam doesn't know either. Sam marries Tracy, who is also a carrier. They had 3 children. Because both of them are carriers, they now have those statistics that 25% of their children could have cystic fibrosis, and in the case of them, Sarah did contract it. Paul and Adam are carriers. So in the case of Sarah, she marries somebody who has cystic fibrosis, and because of that, 100% chance that their child, Michael's, having it too. So this is an example of how cystic fibrosis is carried through the generations and how it could possibly be silent. Genetic testing and what symptoms would lead the patient to even seek help. The following are signs and symptoms of an infant when there is no knowledge if both parents are carriers of CF. The child might have difficulty swallowing and choking, gastroesophageal reflux, GER, with or without choking, and chronic cough with a failure to thrive. And the key word there is failure to thrive. This is a child that doesn't simply have a cold or some kind of respiratory illness. This is a child who's not gaining weight, lethargic, weak. Something is clearly wrong with this infant. Severe combined immunodeficiency and other immunodeficiency disorders. Individuals with immunodeficiency may present with recurrent respiratory infections and chronic diarrhea in infancy. These individuals are also prone to non-respiratory infections like ear infections and skin infections that are not specifically associated with CF. Asthma. CF and asthma both present with chronic cough and persistent wheeze following respiratory viral infections, allergen exposure, or exertion. If there is knowledge of both parents being carriers of CF, the infant would immediately be genetically tested for CF, being that the infant would have a 25% chance of inheriting the disease. So here's the genetic tests. The following test is to diagnose cystic fibrosis in a non-infant when there is a family history of the disease. One or more characteristic signs and symptoms of CF and evidence of an abnormality in cystic fibrosis transmembrane conductance regulator function based on one of the following. So this could be a toddler or child. They need to have 2 abnormal quantitative pilocarpine iontophoresis sweat chloride values tests, an identification of biallelic pathogenic or likely pathogenic variants in CFTR, and transepithelial nasal potential difference measurements characteristic of CF. In an infant when there is a family history of disease, at that point you could cut straight to the chase. You need to test for elevated trypsinogen on newborn screening immunoreactive trypsinogen assay, the IRT test, and you need to have an identification of biallelic CF-causing pathogenic variants in CFTR or an abnormal sweat chloride value. You could also do single gene testing with or without family history. So this is the targeted analysis of the CFTR pathogenic variants that can be performed first. And then if it's inconclusive, you could do a sequence analysis of CFTR followed by gene targeted deletion duplication analysis. And that's performed if only one or no disease variant is found. You could also do a multi-gene panel that includes CFTR and other genes of interest that may also be considered. The multi-gene panels, they may include genes that are not associated with the condition discussed, so the clinicians will need to determine which multi-gene panel is most likely to identify the genetic cause of the condition at the most reasonable cost while limiting identification of variants of uncertain significance and pathogenic variants in genes that do not explain the underlying signs and symptoms. So they need to choose the right multi-gene panel. And then also methods used in a panel may include sequence analysis, deletion, duplication analysis, and or non-sequencing based tests. So instead of doing that sequence and targeted analysis, they may want to do a multi-gene panel that includes everything just to cover all your bases. Testing can be done at any time. If an infant is suspected of having the disease or having signs or symptoms of CF or a family history of the disease, they can be tested at that young of an age. If an adult knows they are a carrier, it would be recommended that their partner be genetically screened before any possible pregnancy to help with family planning. Early detection is important. The sooner an infant is determined that he or she has the disease, the better for health management and survivability. If a person knows they are a carrier, they can better prepare for their own family planning. The disease outcomes. There is no cure. It is lethal. There have been great strides in the last 30 years to manage the disease in some patients. Depending on which organs the disease is concentrated, with focused medical management, patients have been known to live into their 60s or older and have children themselves. If the disease is concentrated in the lungs, there's still a high likelihood that the patient will die in childhood or early adulthood. And here are my references. And I just want to thank you all for paying attention to this, and hopefully you learned something about cystic fibrosis, and I hope you have a good rest of the day. Okay, bye-bye. If I can stop this.